So thank you very much. I'm going to talk to you today about self-management education, which of course will be something that can be provided to people who are in the community at the primary care level. So what I'm hoping to do is talk a little bit this morning about the concept of self-management itself, the differences between self-management education and what we might term more traditional patient education, and to give you a brief description of the chronic pain self-management program, and then provide some evidence from 2 randomized controlled trials that I've done on the CPSMP to show you that there is evidence that this can be helpful for patients in the community. Now, Ted has already mentioned that 3% of people in Alberta have severe quite limiting chronic pain. Epidemiological evidence seems to vary considerably depending on the studies you look at. But, you've got a very wide range of up to 14 to 39% of the adult population in a number of studies say that the adult population suffer from chronic non-cancer pain. And even if that's only mild to moderate, that's still a lot of people who are suffering and who are having to manage this problem in their everyday life. And we all know that pain can result in deep distress and disability for people, and it can really cause major disruptions to both the individuals themselves and to their families, because this isn't just an individual problem, it affects the whole family. And of course, it also affects economic situations, and it's the 3rd leading cause of absence from work in the United States. Canadian data, I'm quite sure, is not very different. And we also know that the economic impact overall to society is high, with an estimated $61 billion in the US. We have a real problem of access to services. Perhaps here in Calgary that isn't as evident to you, but in most of the rest of the country there is really real concern around access. And if 30,000 people in Calgary have severe chronic pain, you know yourself there's got to be an access issue. So that in spite of high prevalence and impact, access to timely and appropriate care still remains problematic. Pain treatment centers with sufficient scope and complexity to address the multidimensional nature of the pain experience tend to be in tertiary care facilities, and they have limited capacity. As Ted pointed out, we often, we know that multidisciplinary approaches are best for people who have chronic pain, but they tend to be costly. You need well-qualified people to deliver those sorts of services, so access continues to be an issue. So, what we're going to talk about is that as an adjunct to usual care in primary care settings, pain self-management education is receiving increased attention. And this could be, if we thought of this as part of primary care, we may be able to increase the access to education for people with chronic pain. In terms of the history of self-management, this term was actually first coined by Thomas Greer in the 1960s. He was working in Colorado, and he was actually working with children in the 1960s. And this term denoted patient or client's active participation in day-to-day treatment. The whole self-management idea emerged as a major research priority in the 1980s, following prevalence studies of chronic illness in the 1960s and 70s. And with that, there was a realization that chronic disease and pain prevalence worldwide was going to have such a huge impact on health systems that we were going to have to start looking at how patients could themselves start taking over and managing their own chronic illness conditions. This led to major critiques of standard healthcare delivery as being too narrow in focus. We weren't thinking broadly about how we could educate patients themselves. What are the limitations to traditional patient education? Traditional patient education is often fairly narrow in scope. It tends to focus on technical self-care skills and specific disease-related information. The client is often very passive in receiving the information. It's very much like what I'm doing to you now. I'm giving you a talk, and you're sitting there just listening to it. That's fine if all you want is the knowledge. But if you have to integrate that into your way of thinking and being a passive recipient of information isn't going to get you there. Also, traditional patient education lacks adequate complexity to address the varied issues related to long-term conditions and comorbidity. And what we mean by that is that chronic illness conditions mean that people have to start understanding how they're going to manage this day to day. And it isn't just the illness they have to manage, it's the consequences of the illness, how it affects their families, how it affects their work life, how they're going to manage day to day. There's a lot that they have to figure out. So the thing is, with tasks in chronic conditions, individuals will need to manage all these day-to-day activities, their medical treatment, they have to manage their symptoms, they have to manage the physical, emotional, and social consequences of their chronic condition, and lifestyle changes that happen with their condition. So they have to manage the inherent living every day with their chronic condition. And traditional patient education doesn't often get at those elements. So self-management education, what is it? These are programs that are based on adult learning principles that provide patients and clients with the skills to live an active and meaningful life with their condition. And these skills include problem solving, decision making, finding and using resources, building partnerships with the healthcare team, and taking action. In other words, that type of education isn't just about understanding why they might have pain, figuring out the medications they should take. It's about all the things that they have to do to manage their condition every day. So those are much more complex skills. The 5 key self-management skills that help build this knowledge, I think I've already mentioned all those. They have to manage their medical treatment, their symptoms, their physical, emotional, and social consequences, and their lifestyle changes. Now, what self-management education isn't? It's not traditional patient education in that I give you information about the disease. It isn't, I'm the expert, and I'm telling you what you should do, because you don't know, but I do, because I have all this knowledge. That's not what self-management education is. It isn't about lecturing like I'm doing now. It isn't about waiting for patients to ask for help. In other words, needs assessments. It's really being proactive and asking them what they need. So self-management education gives people the tools to help themselves and to be proactive rather than reactive. So why is this important? One of the things that Kate Lorig, who was a developer of the Stanford group of self-management programs in the United States, she's done a lot of writing in this area. And she talks about of course, the key thing is that patient self-management is inevitable. They will manage one way or the other. They can manage their condition well, or they can manage their condition poorly, but they're going to self-manage one way or the other. So the professional's role is to be in partnership with the patient. Professionals are experts about diseases and treatments, but patients are experts in their own lives. And chronic conditions are really long-term. They have to figure out how they're going to manage their illness condition within their own life and within the life of their families. One of the things we do know why self-management is important is that outcomes are better when patients are actively involved, have skills to deal with the consequences of chronic conditions, and believe in their ability to do so, which is this whole area of self-efficacy and confidence. And this idea of confidence building is extremely important in self-management programs. Dr. Lorig would say that it is actually the key thing that you try to do. You give people opportunities around getting a whole skill set around how to manage a chronic condition, but you have to build your programs so that you're building confidence. People who have confidence are willing to take a few risks, are willing to try different things, are willing to keep on going. But if they have no confidence, they become passive. So that whole concept of building confidence is absolutely critical. Now, when I was working on my PhD, I went to McGill University in 1990. I'd been interested in chronic pain for quite a long time. I had worked as a nurse practitioner in northern Newfoundland, and I had my most challenging patients were people who had chronic pain for whom I had absolutely nothing to offer. And I just didn't know what to do. Likewise, the physicians that I worked with felt just as stumped about what we could really do to help people. So when I went back to do my master's degree at Memorial, I was very interested in chronic pain. And then when I went on to McGill, I continued on with that area of interest. My supervisor at the time was Mary Ellen Jeans, and she said to me, now, all these descriptive studies are just fine, she said, but you have to do an intervention. You have to try to find something that's actually going to make a difference. And I thought, oh, well, gosh, let me invent the atomic bomb. I mean, it's like, oh, that's simple, It was really like I was just, oh, goodness gracious, what was really going to happen? I mean, that was what I was trying to discover when I went to university. Anyway, of course, I started looking in the chronic pain literature, and I didn't find very much. I mean, I found programs that were, in hospital, 1-month programs, multidisciplinary, extremely costly. And I thought, well, I mean, that's not feasible. And you wanted to have something that was accessible, low cost, community-based. And I didn't find very much in the pain literature. So I thought, okay, well, let me move to, a sister kind of problem, arthritis, because the arthritis people don't seem to talk to the chronic pain people. We seem to have a distinction between those areas. So I went to the arthritis literature, and I started finding some really good, well-designed studies on the arthritis self-management program. Dr. LeFort had started these studies in the late 1970s. The Surgeon General in the U.S. had started identifying the concerns around chronic illness, especially arthritis, as the population was aging, realized that the health system was not going to be able to cope with this condition over the long term, and started to ask questions around, look, we've got to have better interventions around how to help people help themselves. So Dr. LeFort started these studies. She developed, over a long series of sort of trial and error of different types of programs, she came up with the arthritis self-management program. What was so great about this was that there was a strong theoretical base to the program, self-efficacy theory, and it was very strongly based on adult education principles. I hadn't seen that in very many programs. They were just kind of cobbled together, if you will. So this had a very strong theoretical base. It had been tested in 4 randomized controlled trials with over 900 people in these studies. There was an additional trial that had used a comparison group to evaluate the long-term impact at 20 months. And what they found in terms of these outcomes was that there was significant improvement in knowledge, exercise and relaxation behaviors. Pain was reduced. There were positive trends to the reduction of depression and disability, and these improvements were maintained and were associated with reduced healthcare costs up to 4 years post-intervention. Now, the healthcare reduction in cost wasn't big, but if you talk about the number of people who have the condition, as a whole, it was a large increase. And interestingly, the improvements, the positive outcomes of the program were not linked to behavior change. We've been in a model for quite a long time that if we can help change people's behavior, they will automatically have better outcomes. What LeFort's studies found was that actually that wasn't the case. It wasn't necessarily the people that changed their behavior. It wasn't the people that exercised more or the people that relaxed more or whatever. It was the people who had higher levels of self-efficacy, this concept of confidence. So there's something really important about that we have to instill in people. It's not just giving them the information and having them actually do the better behavior. It's they have to actually have a different outlook on their situation and on themselves as active agents. So if there's anything that's really critical for you to understand, is it's that capacity that people have to be confident that they have some control over their chronic pain. So having looked at the arthritis self-management program, I actually went to a session. I had decided that if I was going to do an intervention, I might as well do it at home where there were basically no services for people. So I went back to Newfoundland, and the Arthritis Society in St. John's was running self-management programs. And so I thought, okay, I'm going to go and sit in on these programs and and look and see to what extent this is something I could use for chronic pain. And sure enough, there was an awful lot that I could see was very generic. There were certain content areas that would have to be changed, but there was something about the process that I could understand why this had been successful. So when I talked to Dr. LeFort about revising the program for people with more general chronic pain conditions, what she said to me was, you can do anything you want with the content, but don't mess with the process. So I didn't. So I left the process elements just the same, and I'll refer to that in a minute. But I did change some content, about 40% of the content. So we provided information about chronic pain versus acute pain. We had a little introductory session on myths about chronic pain, meaning about pain, that sort of thing. I included sessions on pacing, how people have to balance activity and rest. Exercise, hurt versus harm, a major problem for people with chronic pain. And then subsequently, I've developed with a colleague, Lisa Cardis, a special exercise program called the Moving Easy program that we teach in the CPSMP. There's a new section on, or it's a modified section on nutrition. In large part, lately I've been able to incorporate some of the new work by John Pereira, who I think is giving a workshop later today. We have a section on relaxation techniques, communication about pain, and medications, analgesics, adjuvants, and opiates. So I got permission from Dr. LeFort to modify the program, and what it is it's a standardized community-based program that's been adapted from the arthritis program and most recently from the chronic diseases self-management program, which Stanford has had out for about the last 5 years. It teaches self-management skills and is designed to enhance this sense of confidence, self-efficacy, and it runs for about 2.5 hours a week for 6 weeks. With 10 to 15 individuals along with facilitators, 2 facilitators. So this is just to give you an idea of the way the program is set up. At the top of that table, you'll see that there's week 1 to 6, and then down the side are the topics. So each week, you will see that exercise is a critical piece, that pain management is discussed five weeks, and you'll see that there's problem solving and feedback every week. And this is the kind of thing where the process is so important. People need feedback to see how they're doing. In terms of the process, the program has what they call mini lectures. There is, of course, we give people information. They need information specific to their chronic pain condition, but it's in small bites. And they also get a workbook that goes with the program. They're adult learners. If they want to learn more, they can read that section in the book. But the 2.5 hours isn't about giving people information. There's a lot of self-reflection, sharing of feelings, what chronic pain means to me, communication issues. There's quizzes, myths about chronic pain, and there's a lot of brainstorming about the benefits of exercise, symptoms of depression. They also set weekly contracts, or what's now called action plans, where they learn the process of setting short-term goals. Because this is a critical thing. A lot of people who go into something new will, set their goals too high. If you set your goal too high, you're going to fail. You lose your confidence. So the way the program has been set up is that each week you try to help people set goals for themselves for the coming week that they can actually achieve. Because what you're trying to do is help them understand that they can set goals and they can be successful. And then they start building their confidence. There's feedback about how well they're doing. There's group problem solving. And there's telephone support midweek with their peers. as I mentioned, this idea of contracting or action planning is really a critical piece. The idea is to help people set achievable short-term goals that they can work on each week. And there are guidelines to these action plans. They have to identify something they want to do. It has to be realistic. It has to be specific. They have to write it down, and they have to check it every day. One of the things that was really interesting when I first started this was in the arthritis self-management program, so you have to remember this is about 1995 now, the arthritis self-management program had decided that for people with arthritis, the most important thing they could do is exercise. So they wanted people to exercise, and they kind of, in a sense, said, yeah, you can do your own action plan, but it has to be about exercise. I was sitting in on those sessions, and I thought, for people with general chronic pain problems, I thought, you know, that doesn't sound like adult learning to me. I think people have to be able to set their own goals, because for people with chronic pain, their goal might be they need to do something that makes them feel good about themselves, or they need to pick up a hobby that they stopped, but that used to give them pleasure. I mean, there are all kinds of ways to set goals for yourself that will help you manage your chronic pain. So that's one of the first things I did, was to say it can be about anything you want to do. And in fact, subsequently, the Chronic Diseases Self-Management Program has done the same thing. So it's just been an interesting shift about how, certain kinds of thinking still needed to be modified and changed. I just wanted to share an example of an action plan that one gentleman did when he was in the program. Now, this was a 32-year-old married man with one child who was about a year old, and his partner, his wife, was, as he described her, somewhat supportive of his situation. He had had chronic pain for 10 years, which developed after an industrial accident. He had actually fallen over a bridge 10 feet onto a highway at the age of 22. He had had 5 spinal fusions. He was back at school doing an IT program, but really finding it difficult to sit for long periods of time. And his goal was he really wanted to increase his activity and to spend more time with his daughter. And he was feeling badly about his wife having to carry the burden at home and wanted to give her a break. So he did, in fact, make an exercise action plan, but he incorporated that by walking his daughter in her stroller before supper. He started with 10 minutes 3 times a week because he really wasn't doing anything very active at all. So 10 minutes 3 times a week. That's all he had to do. Monday, Wednesday, Friday, or Monday, Wednesday, Saturday, whatever it was, but he had to write down the days and the times that he was going to do it. And 6 weeks later, he was walking 40 minutes, 4 to 5 times a week over the 6-week program. Now, he was just as shocked as the rest of us in the group, to be honest, because he never thought he could do it. But he was such an inspiration to other people in the group. And that's another key thing about the self-management programs, is the facilitators are often peers. It doesn't have to be a healthcare professional. And in fact, Dr. Lorig thinks that the programs can work best if they're not healthcare professionals, or if the 2 facilitators, one of them is a peer and one of them is a healthcare professional. But the thing is, because they see that someone just like themselves can achieve these small victories, if you will, and it gives them confidence that they can too. So I'm going to tell you about the 2 randomized trials that I did. The first one, so this was in 1996. I received funding from the National Health Research and Development Program from Health Canada to do a randomized controlled trial in St. John's, and I subsequently published 2 papers from that study. There were 110 people who came into the study who had chronic pain. I had taken them from a roster from a chronic pain wait list from 2 anesthesia departments at our local hospitals. Plus, I had sent letters to about 100 primary health care providers in the city of St. John's, letting them know about the study and asking them to let their patients who had chronic pain know about the study. So we had 110 people come into the study, and they all completed the pretest measures, and then they were randomly assigned either to take the treatment, which was a 6-week program, or to be on a wait list. And the people who took the treatment had a 6-week program, and then we had a 6-week wait, and then we took post measures 3 months after they came into the program. And likewise, the waitlist group had a 3-month wait. We did post measures with them, and then if they wanted to, they elected to come into the program after that. At that time, of these 110 people, the mean age was, about 40 years old. And they were as young as 24 and as old as 60 years old. But this is a young group of people, midlife, who have really significant pain problems that interferes with their ability to live a regular life. 73% of them were female. 89% of them were high school graduates. So this is a high, relatively well-informed group. Only 38% of them were working, and they weren't working because of their chronic pain. A couple of them were stay-at-home moms, but most of them declared that they weren't working because of their chronic pain. They had pain for a mean of about 6 years. They had multiple pain locations in their body. 68% of them had back or neck pain. 81% of them were taking medications for pain. And 62% had seen their physician within the past 30 days. Now, we know that one of the things about chronic pain is that they are very heavy users of the healthcare system. So this is just borne out time and time again from different studies. Well, as I say, when we looked at the group of people who took the program, they're in the darker blue, and the control group is in the green. What we found was that the people who took the program had significant improvement in the area of problem severity. We asked them how severe they perceived their pain problem to be, and 3 months later, they were significantly different from the control group. Likewise, they were less dependent on others, so they had less dependency on others 3 months later. They had higher levels of self-efficacy, higher levels of resourcefulness. They perceived that they were able to engage in more valued adult roles after the program than their counterparts in the control group. And they were more satisfied with their life overall after taking the program. And just to let you know that the two groups were equivalent at baseline. So when we did the pretest measures, both the control group and the treatment group were exactly the same. So we inferred that the differences were due to their intervention. In terms of the MOS, Medical Outcome Study Short Form 36, I don't know if you're familiar with that tool, but the MOS SF36 is one of these measures that's now used in lots of interventions. It's scored so that higher scores are better. So what you see here is that the blue group, which is the treatment group, had higher or better scores on pain, better scores on vitality, and better scores on physical role functioning. So their pain was reduced, they had higher levels of vitality, and they were more physically active. So we found then statistically reliable improvement in health status measures. There were improvements in the treatment group that ranged from 9 to 47%, with most in the modest range. Remember, this is a 12 to 14-hour program. It's what I think of as the Volkswagen version, right? There's the Volkswagen version, which we can offer in the primary care settings in the community, and then there's the Cadillac version. There are people who are going to need much more intensive support and individual counseling or different types of group education. So we're not trying to say that this is the be-all and end-all, far from it, but this is an adjunct to primary care in the community that can have positive outcomes. And that for some people, it's a kickstart And once they've gotten the idea of self-management, it really triggers a whole other way that they start managing their chronic pain. And what was really, I guess, positive was that our results were comparable to the results of the arthritis self-management program and to the chronic diseases self-management program, as well as to other sort of short-term pain programs that had been reported in the literature. So our results were actually a little better than the arthritis studies. And the results continued to support self-efficacy theory, this idea that confidence building and increased problem solving lead to better outcomes. And the other thing that people told us, I mean, quantitative measures are great. It gives you, very valid, reliable measures. But it's also important to hear people's voices to tell you what they thought. And we did a bit of a qualitative analysis as well, because we asked people at session 1, what does chronic pain mean to you at session 1? And then at session 6, we asked them again, what does chronic pain mean to you? What they heard us, or what we heard them say was that that being able to be part of a group process meant that they had their voice heard. They were validated. As you know, so many people with chronic pain aren't quite legitimate in the healthcare system. They don't have an X-ray or a blood test or something that's an indicator of their chronic illness condition. And so being heard and feeling validated was really important to them. Knowing they are not alone. I couldn't believe the number of people who said they had never talked to another person who had had chronic pain, that they had gone to the physiotherapist for years and sat beside people who must have had chronic pain, never talked about it to somebody else. Sharing with others who understand. And they said that they really found it important that they were in a safe environment. It's been extremely beneficial to share my doubts and fears in a safe environment and has helped me to feel a little less alone and overwhelmed. And the other thing they talked about was taking ownership, that the cure for my chronic pain will most likely be from myself, as opposed to the magic bullet, something's going to happen and they're going to find a new pill or a new surgery that's going to do this. Well, that was all very well. I had done this first set of studies. I had been the facilitator. And as I say to my students, you will never be as committed to anything in your life as when you were doing your PhD study. So it's an efficacy trial. It's done under the best of all possible conditions, right? That's what most randomized trials are, drug trials included. They tend to be done under the best possible set of circumstances. But we know when you bring that into real life, into real working conditions, sometimes people slip up. They don't take their pills 4 times a day, they take them twice a day, so on. So anyway, I needed to do an effectiveness trial. How effective was it going to really be in the workplace? So I did a larger study in varied rural and urban sites, 3 in Newfoundland, 1 in St. John's, and then 2 in smaller centres in Newfoundland. I did 2 in Toronto and 1 in Halton, which I have to laugh at because they thought of Halton as rural. Now, if anybody knows Ontario and Toronto, I mean, Halton is a bedroom community of Toronto, and I would hardly think of Oakville as rural. But anyway, that's what we got. And then we did one site in Regina. The facilitators were community-based nurses because we were looking to see whether we could integrate this into the community-based care model. We used Victorian Order of Nurses in Newfoundland and in Toronto, and allied healthcare providers in Regina. We did baseline measures, 3-month measures, and 12-month data collection on major study variables. And we also had people keep a pain diary to track economic costs. Now, this was 10 years later. Remember, the first study I had done was around 96. This was about 96, let me think. This was about 2004, so not quite 10 years later. The mean age of the population was 48. They'd aged. Oh, goodness. 80% of them were female, 31% of them were working. Mean pain duration was 9 years. 75% of them had back or neck pain. 90% of them had had a visit within the last 30 days to their healthcare provider. Very, very similar. What we found in this study, we had 207 people in this study. We had statistically significant change in the mental health composite score of the SF-36, and that includes vitality, social and emotional functioning, and mental health. And we had statistically significant change in the measure of resourcefulness, which also includes a measure of confidence, problem-solving ability, ability to delay gratification, and positive reframing. And we also had positive trends to improvement in measures of disability, psychosocial adjustment to illness, and life satisfaction. And we followed 80 people. Of that 270, we followed 80 of them 12 months later, and these results were maintained at 12 months. Remember I said that we had asked people what chronic pain meant to them at session 1 and then again at session 6. What this group told us was that what chronic pain meant to them was just a succession of losses. No energy, lack of concentration, loss of the person they used to be, loss of self-esteem, of their independence, of control over their lives, pain rules, loss of financial security. One quote was, "A silent cross to bear because you can't go around complaining all the time." What they said at session 6 was that they had learned from others, and they had helped others, and they hadn't done that in a long time. And they felt good about helping other people. Because what's always interesting in these groups is that you have to have enough people so that you're probably going to have some people who are actually pretty highly functioning, and then you're going to have others who are very low functioning. And the low functioning people will start to realize that the other people with chronic pain are doing well. And so they're learning from each other. They had validation. And they talked about coming to terms with the fact that this was going to be a chronic condition that they were going to have to manage. They talked about increased self-esteem. They had more knowledge and self-knowledge. They had hope and direction for the future, and they were learning to manage. In terms of the cost, what we found for the 3 provinces was that the median cost for Newfoundland was around annual costs per year, was almost $10,000. And this included both direct healthcare costs and indirect costs. So indirect costs were things like, I have to hire somebody to come and cut my lawn because I can't do it myself. I have to take time off work so I can go do my clinic, so I can go to the doctor. I have to have my wife drive me to the clinic because I can't drive myself anymore. I have to have somebody come in and look after the kids an hour a week because I just can't manage it all the time. So there are a lot of indirect costs that haven't been built into the way we look at costing of chronic conditions. So in Newfoundland it was around $10,000. In Ontario it was a little higher, around $12,700. And in Saskatchewan it was lower at $5,600. But they've got a different insurance system, and that accounted for those costs. In all 3 provinces, the costs were highest for younger participants, those who were not working, and who had more education, and who lived with another adult. There was a decrease in indirect healthcare costs for men who participated in the chronic pain program. So we were looking to see whether participation in the CPSMP actually decreased costs over time. We didn't find it for the direct healthcare costs, but for indirect healthcare costs, there was a reduction for men. And I can only think that men started doing a little bit more for themselves. So in conclusion, I think the results of the studies that I've done to date suggest that community-based healthcare providers, such as registered nurses, can reliably deliver the program. But again, we really need to be testing this out with peers, because the other self-management programs do use peers. It showed positive outcomes at 3 months that can be maintained for some people up to a year. The CPSMP appears to reduce the indirect costs of chronic pain for men, and the results continue to support self-management education approaches. I did these studies as one clinician researcher trying to implement a community-based approach as an adjunct to traditional care for chronic pain. This is not meant to replace anything that's going on in the community. Visits to healthcare providers, visits to their primary care physicians, to physio, or whatever else they're doing. This is an adjunct to that. We need to have buy-in from the local health authority to incorporate self-management into mainstream care. And there are really great examples of this that are already happening, one of which is in your own health region. The Calgary Health Region has integrated the chronic diseases self-management programs into their model of chronic disease management. And in fact, I just gave a workshop in Edmonton last week to the Capital Health Region, and 4 people from the chronic diseases management group from Calgary came up for that. So you've got 4 people in Calgary who have been cross-trained to do the chronic pain self-management program. So I think your health authority has already bought into the concept of self-management, so you can already build on that. The other places that are doing a lot is the state of Vermont. The whole state of Vermont has a chronic diseases approach, and so everyone in the state is eligible to have chronic disease programs or self-management programs. And the Calgary Health Authority one, the Chronic Diseases Self-Management Program, they've titled Row Your Own Boat, so you might know it under that title. The Chronic Pain Management Centres in Ontario are using the Chronic Pain Self-Management Program, and I did a training program in August with the province of British Columbia, so they'll hopefully be starting to roll it out as well. We also have a newly funded grant from CIHR, Canadian Institutes of Health Research, on pain and knowledge translation. And I'm the principal investigator for the first theme called From the Ground Up, where we're going to be exploring patient, family, and health system needs, including self-management programs. I'm not suggesting that the program I developed is the only one there is. There's not. I mean, I'm sure there are many approaches to self-management programs, but the key elements around building confidence and the elements that I've talked about, I think, are key to any self-management program approach. I think we probably need a variety of models to try to provide even greater access. You'll notice that the large number of people who come into the chronic pain programs are women. Men need something else, maybe. I'm not sure what, but should it be on the net? Should it be... there needs to be different ways to provide this type of education for people. And there are other Canadian initiatives going on. Mike McGillian, who is a faculty member in nursing at the University of Toronto, adapted the chronic pain program for people with chronic angina pain and had a very successful randomized control trial where they really improved outcomes for people with chronic angina. And Jennifer Stinson, who's at the Hospital for Sick Children, has used these same concepts and is developing a program all on the web, all very up-to-date technologically for teens, called Teens Taking Charge, Managing Arthritis. So there are a lot of really innovative, I think, ways that we could be thinking about delivering self-management education for people with chronic pain and kind of putting them back in the driver's seat. Because there's just too many of them for us to take care of all by ourselves. We can't do it. We have to be in partnership with them, and I think that is going to be the key to all chronic disease management. But for chronic pain, they're ready. These people need some tools and ways to engage in how they can better manage their problems so that they can have a better life. So I thank you very much for your attention.